Good afternoon to everyone present here with us today. This is Treon from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker doctor for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. C.B. Patil. Sir is MBBS, MD, DM Cardiology, FICC, FIAMS, FCSI, FIAE, Wu Fellow in Interventional Cardiology, USA, visiting cardiologist at Sri Shankara Cancer Hospital and Research Center, Shankarpuram. Also, Bangalore Teaching Faculty, Department of Cardiology at Manipal Hospital. Now, with the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is pericardial effusion. Without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Thank you. I thank the IJCP for this opportunity and good afternoon to you all. And I'm just going to touch upon another important topic in cardiology, that is pericardial effusion. Slide movement. Slide is not moving. Can you help?
Sir, can you escape from that full screen?
Yes.
There's an escape button. Just escape from there.
It is not getting escaped. Stop share.
Yes, sir. Just stop share the screen once and then reshare.
Now reshare.
Yes, sir.
Again. Now I will make it.
Yes, sir. Your screen is visible, sir.
Visible. Now
Yes,
shall I make it little?
There's a slideshow option below your screen.
Yeah.
Yes, sir.
But it is not getting enlarged. Yeah, now it is. Yeah.
Yes, sir. Your slides are moving, sir. Thank you, sir.
Yeah. Just to introduce to the topic, I'm sorry for this technical glitch. Pericardial effusion is an abnormal accumulation of pericardial fluid in the pericardial sac, which surrounds the heart. Causes vary from almost can be an inflammatory to non-inflammatory, like malignancies, trauma, all these things. It affects any age, any gender, or a race. Then definitely the clinical symptoms may be there or may not be there. Sometimes may be fatal also. Imaging techniques like X-rays, echocardiogram, and computerized tomography, magnetic resonance imaging, pericardiocentesis help in its detection, evaluation, and of course planning the management. Treatment, which targeting the underlying cause, what is the etiology, its symptoms, size, and rapidity of effusion. All these are very important, and its hemodynamic consequences, for which probably we may have to emergently treat such a condition. Pericardiocentesis or a pericardial window and use of sclerosing therapy are to relieve the symptoms. So what are the etiologies? Let us consider. As you know, the pericardial sac hardly contains 50 to 50 ml of transudate or a serous fluid, which acts as a lubricant between the two layers, the visceral layer and the parietal layer of the pericardium, which permits frictionless movements between cardiac chambers without interrupting mediastinal structures and helps to keep hemodynamic stability. If there is a disrupted drainage, that means increased drainage itself, or an excessive production itself of the fluid due to some inflammatory or non-inflammatory mechanism or a trauma, which leads to more than 50 ml of fluid accumulation, then we call pericardial effusion. And if it is acutely, even 100 to 200 ml can lead to hemodynamic alteration, but chronically when it is accumulating, even it may take days to weeks together to cause a cardiac tamponade. As you know, the common etiology is a viral infection, which is most often a very benign condition, rarely bacterial, which is again little malignant because it has to resolve. Parasitic infections also can lead to pericardial effusions. Cardiovascular injuries, especially during interventions like mitral balloon valvotomy, and of course the left atrial, that septal puncture. Any of these usually they require in even congenital interventions. At that time also pericardial effusion can be there, which is may contain a blood in the pericardial sac. Even aortic dissection type A, malignancies which form almost 10 to 21% of the pericardial effusions, and even external injury which injures the pericardium or the heart chambers can lead to pericardial effusion. Inflammation, connective tissue diseases, autoimmune disorders, especially connective diseases like rheumatoid arthritis, systemic lupus erythematosus, all this can lead to pericardial effusion. Even metabolic disorders like hypothyroidism, renal failure, chronic kidney disease, and who are undergoing dialysis, they can also have a pericardial effusion. Cirrhosis of liver and other underlying comorbidities, even sometimes radiation exposure for the malignancy can later lead to pericardial effusions also. Congestive heart failure, simple which is not controlled, can lead to pericardial effusion. Even rheumatic fever in its acute stage, when it is a carditis, then also it can lead to mild pericardial effusion, but rarely tamponade. Drugs like hydralazine can also lead to pericardial effusion, and idiopathic conditions also contribute. Many times we don't find the etiology at all. Still, pericardial effusion can happen, and they all contribute to the abnormal fluid accumulation. So, what is the pathophysiology under this pericardial effusion? It can be acute, as I've already told you, due to viral infections, all these things, or can be chronic due to malignancies or connective tissue diseases, even CKD, all these things. It can be serous, it can be bloody, like sanguineous or exudative. Pericardium has a limited elasticity, especially parietal pericardium, as it contains the collagen fibers and elastin. Hence, acutely just it can accommodate hardly 100 to 150 ml, which can lead to compression of thin walled right heart chambers, or chronically over weeks together, it can lead to pericardium. So there is a compression of the right heart chamber because they are thin walled structures, and when it compresses, it interferes in its diastolic filling of the right side of the heart, leading to venous congestion. That's how dyspnea can occur in these conditions. And interference in LV diastolic filling leads to what? It leads to decreased stroke volume and cardiac output also. When the cardiac output comes down, even fatigue, dyspnea can be there, and definitely there will be adrenergic stimulation. Tachycardia can occur, which can lead to increased contractility to maintain the cardiac output sufficiently, but eventually cardiac output and BP decline if no interventions are done timely. In chronic cases, fluid may accumulate, as I have already told you, slowly up to 1 to 2 liters before causing a cardiac tamponade. So this is one type of classification. It can be circumferential surrounding the heart, or can be sometimes loculated. And depending on the size, we call mild effusions, that is less than 10 millimeter size in the MOD echocardiogram, hardly posterior to the LV, or moderate when it is present both anteriorly and posteriorly up to 10 to 20 millimeter size, or large greater than 20 millimeter size in the MOD echo, both anteriorly posteriorly. When it's too large, definitely it can lead to cardiac tamponade. Usually mild is less than 200 ml, moderate it could be 200 to 500 ml, and large can be more than 700 ml like that. But acutely, even if it is just 200 ml, definitely it can lead to cardiac tamponade. Depending on the onset, we call acute pericardial effusion when it is less than 1 week duration. Subacute we call when it is more than 1 week but less than 3 months. And chronic we call when it is more than 3 months duration, as in other connective tissue diseases, autoimmune disorders, malignancies, all these things. And I have told you composition can be transudate, as in CHF, all these things can be exudate in inflammatory conditions. And depending on the hemodynamic effect, it can be effusive constrictive, or it definitely a cardiac tamponade can be there, either acutely or chronically, or there may be without cardiac tamponade and maybe without any symptoms. What is the clinical presentation? History, it can be asymptomatic, I have already told you, or history of recent illnesses like viral infections or respiratory tract infections, or there can be a history of a tuberculosis, either being treated or under treatment or under evaluation. Can be malignancy sometimes, which can be detected only by pericardiocentesis and detecting these malignant cells, all these things. Following vaccinations or following injury, history of trauma may be there, or post surgery, especially following cardiac surgeries, there can be a pericardial effusion. Even post MI, we call following about 2 to 3 weeks later, there can be pericardial effusion due to any immunogenic process, or even in chronic kidney diseases, liver diseases, hypothyroidism, pericardial effusions can occur. If pericarditis like fever is there and acute pericarditis, there can be a chest pain which is typically a stabbing or a pricking type of pain radiating to the left shoulder or acromion process. And if there's a more effusion, it can also lead to dyspnea, and which improve with sitting. So this whatever dyspnea or this chest discomfort is there, more in the lying down position and gets relieved in the sitting position. That is a typical history you will get. Increases on lying down, supine as inflamed. Yeah, why it increases on lying down? As the inflamed pericardium contacts adjacent structures. Even non-specific symptoms can be there in the form of a dyspnea, fatigue, edema can also occur. So what signs you will be able to get? In mild cases, especially if it is a viral pericarditis with an effusion, pericardial rub may be heard or may not be heard at all. In moderate to severe cases, there can be tachycardia. And I told you if there's a hemodynamic compromise like cardiac tamponade, hypotension can be there. And definitely, if it's a large pericardial effusion, you see a cardiomegaly, the borders will be enlarged, and dullness can be present in the left second space, and definitely heart sounds may be muffled in large pericardial effusions. So you sometimes a typical Beck stride is described, but it is very rare to see. So what is the Beck stride? Is a raised JVP, hypotension, and muffled heart sounds. So these are seen hardly in few patients. Also, there is another sign called as a pin Ewart sign or an Ewart sign. So what is Ewart sign? Is a dullness to percussion in left infrascapular area with a tubular breath sounds, and egophony can be heard. In cardiac tamponade, sometimes you typically see a pulsus paradoxus. What is a pulsus paradoxus? Is an inspiratory fall of a systolic blood pressure of more than 10 millimeters of mercury due to a collapse of the compression of LV at the expense of the RV. That's why the systolic pressure comes down. This leads to why? This leads to bowing of the interventricular septum and augmented compression of the left side of the heart with decreased filling volumes, thus decreased stroke volume, and definitely the systolic blood pressure also decrease. Normally it is hardly 6 to 7 millimeter fall, but here it will be more than 10 millimeters fall. Then only you call it as a pulsus paradoxus. So numerous imaging techniques are used to evaluate size, its duration of effusion, its progression, whether it is going to tamponade at all, and coexisting pericarditis, underlying diseases like tuberculosis, malignancy, inflammatory causes, connective tissue diseases, and metabolic disorders. All these have to be evaluated. So, how to evaluate? We have got many means. X-rays hardly have got a limited role. It have got a low sensitivity. Only it can help in a large pericardial effusion. So you can see what is called as a water bottle appearance with oligemic lung fields. And rarely pulmonary edema can be there. Engorged vessels can be seen. Atelectasis sometimes, and pleural effusion can be seen. I'll just show you a X-ray picture here. So this is an X-ray. I told you the cardia is definitely enlarged. It's called a water bottle appearance or the leather bag appearance with an oligemic lung fields. This is a typical chest X-ray in a large pericardial effusion. The X-ray can be abnormal only when the fluid is more than 200 ml. Otherwise, it cannot be detected at all. Now, coming to the ECG. ECG may be normal, or if there's a acute pericarditis like viral pericarditis, PR depressions can be seen, diffuse ST elevation can be there. Small pericardial effusion, there can be sometimes non-specific STT changes can be there. Whereas in a large pericardial effusion, what is called as a electrical alternate occurs due to swinging movement of the heart in the large pericardial effusion. So this is an example of the, see this, there's a tachycardia is there, and there's a, there's a alternate beats are large and small amplitude beats are there. In the, especially as you can see in this arrow, no, definitely one small and one large amplitude beats are there. This is called as pulsus alternans. So there is a low voltage, there is a tachycardia, and there's an alternating amplitude of the electrical, that is QRS complexes. So this is typically seen in a cardiac tamponade. This I have already shown you, the chest X-ray in a large pericardial effusions. Now coming to the diagnosis, typically it can be diagnosed by an echocardiogram. That is the is a modality of choice to detect as well as to assess its rapidity, its progression, all these things. It's a diagnostic modality to assess size, location, progression, whether it's going to tamponade by serial echocardiogram. So how will you see this fluid? It is an anechoic fluid between pericardium and epicardium. If there is an exudate or blood is there, then it will be little hypoechoic, not completely anechoic. Epicardial fat moves, whereas if there is even epicardial fat can be there, but it moves with the heart chambers, whereas fluid cannot move in cardiac cycles. And usually epicardial fat is little hyperechoic. It is not hypo or anechoic. Normal pericardial fluid is seen only during systole. That also you should remember. So depending on Wiseman et al., they classified pericardial effusion as small when it is 10 millimeter and just below the LV in the M mode echocardiogram. Moderate 10 to 20 millimeters as well as seen anteriorly as well as posteriorly. Large when it is more than 25 millimeters size, and very large we call more than 25 millimeters size. And if right atrial free wall along with a large pericardial effusion, if you find right atrial free wall collapse, especially in systole, it is also called as a right atrial inversion in systole, and RV free wall collapse in diastole, and along with this, if you see septal bowing or a bowing in a right ventricle during expiration and LV during inspiration, and higher flow across mitral wall during expiration, that is by through the pulse wave Doppler, and across tricuspid wall during inspiration, all these indicate that the intrapericardial pressure is quite high compared to the cardiac chamber pressures. So that means there is a cardiac tamponade. So you can see here, there is a fluid in the just below the LV side, and definitely it's surrounding the heart. And here also you can see the right atrium. Right atrium is you can see that there is a systolic collapse is there. RA systolic collapse is also seen in this, and along with fluid surrounding the heart, which is anechoic. And again you can see that there is a swing. I can't play this thing, but you can see that in the expiration, when you see the Doppler in the mitral, across the mitral wall, definitely there is a expiratory fall in the amplitude of the Doppler waves. So that's what you find. Whereas inspiratory fall will be there in the tricuspid wall. That's what you see. And CT is also helpful for, that is computerized tomography, accurate location, extent, quantity of fluid, and when pericardial nature is complex. So R has clots. Definitely CT also definitely helps, especially when the echo windows are poor. Definitely it is going to help. To differentiate pericardial fat, thickening of the pericardium, long-standing inflammations, exudates, clots, all these things can be made out in the CT. Thoracic and sometimes associated thoracic and mediastinal malignancies can be made out. Composition of fluid can be seen by its attenuation values. If there is a serous fluid, it is less than 10 Hounsfield units. Hemorrhagic fluid can be more than 60 Hounsfield units, whereas in between, that is an exudative, between 10 to 60, it probably indicates that it is an inflammatory etiology. All these things can be made out in the CT. And the cardiac MRI rarely helps. Definitely when the echo window is poor, when differentiation of long-standing PE comes, and especially is there any constriction versus restriction. All these things can be made out through the cardiac MRI, whether there is a constriction with effusion is there. And to differentiate the clots and complex nature and loculated effusions, all these things are well made out in the cardiac MRI also. And to differentiate associated masses, pericarditis, myocarditis also can be made out through the cardiac MRI. So this is cardiac CT in a pericardial effusion. You can see that there is a fluid surrounding the heart is there, and that is well made out. If there is a thickening of the pericardium, that can also be made out with in the CT. And this is a MRI in pericardial effusion with the T2 gated images. Definitely that also indicates there's a pericardial effusion is there. And so coming to the proper diagnosis, sometimes pericardiocentesis, even though it is not essential for diagnosis, but can be done if there is a large effusion. But for cardiac tamponade, definitely it is indicated. And to establish, is it a bacterial etiology or a neoplastic etiology, its chemistry, cytology, and biomarkers, tumor markers, and a polymerase chain reaction for specific infectious agents, and its microbiology, like sometimes AFB can be seen, and sometimes culture sensitivity tells you what is the etiology, and of course the serology in other conditions. Further tests like screening for neoplasms, autoimmune diseases, thyroid, and other metabolic disorders also needs to be analyzed to find out the etiology, and lab analysis for other infections and connective tissue diseases. All these things have to be evaluated. Needle pericardiocentesis is indicated for moderate to large effusions, and it is usually done under local anesthesia with echo or a fluoroscopic guidance only it is done. Rarely, while doing, there can be ventricular tachycardia. Sometimes injury to the intercostal vessels can occur. Chamber lacerations can occur. Pneumothorax can occur. All these complications are rare up to the extent of 1.2%. Very, very rare is the mortality, hardly less than 0.09%. And of course, definitely, percutaneous balloon pericardiotomy also helps. If drainage continues, it needs a pericardial window has to be done, and catheter drainage have to be put, and sometimes sclerosing therapy may be required for relief, especially in malignant pericardial effusions, just to prevent it. And drain pericardial effusion to an so whenever there is a large pericardial effusion with a tamponade, if there is an underlying ventricular dysfunction, if it is there, then definitely just a drain to give relief to hemodynamic stability and to achieve the stability and avoid pericardial decompression syndrome, sometimes which is definitely a serious condition in those with an underlying LV dysfunction. Hence, relieve to a certain extent, then gradual drainage can be continued with the help of a catheter and all these things. So what are the differential diagnoses for pericardial effusion? Acute pericarditis, maybe viral, or cardiac tamponade, I have already told you of various etiologies. Cardiogenic pulmonary edema is another condition to be kept in mind. And constrictive pericarditis, dilated cardiomyopathy, effusive constrictive pericarditis, myocardial infarctions, pulmonary embolism, these are all differential diagnosis. You have to keep it in mind whenever there is a discomfort along with breathlessness is there. So what further management for recurrent pericardial effusion or malignant pericardial effusions? Pericardial window is a safer alternative which is done by surgery or through the video assisted thoracoscopy, and pericardium is excised and fluid is made to drain to mediastinum by subxiphoid route or by transpleural drainage into the thoracic cavity. So better is always it should be done with the help of the cardiothoracic surgeons. In recurrent pericardial effusion, as in malignancy, sclerosing therapy, as I have already told you, sclerosing therapy using colchicine, bleomycin, cisplatin, tetracycline, and doxycycline are used to prevent recurrences by inducing inflammatory adhesion of the pericardial layers and prevents reaccumulation. In that way, it's definitely going to help. Bleomycin appears better versus tetracyclines in some of the trials. Avoid this therapy if there's a good life expectancy, as it leads to constrictive pericarditis later. That's why if there's a good life expectancy, avoid this therapy. Now coming to the prognosis. So definitely that depends on the underlying cause for the pericardial effusion. It is good in idiopathic or a viral pericarditis, and usually if it has poor prognosis and high mortality is seen in fungal and bacterial pericardial effusions, and definitely poor in malignant pericardial effusions due to advanced disease. If pericardial effusion is due to the connective tissue disorders, it also depends on the underlying cause of the connective disease and its response to immunotherapy, all these things. In chronic idiopathic pericardial effusion, usually the prognosis is good and tamponade, but still can occur even in these conditions. So just to conclude my talk, pericardial effusion is a common condition, has many complex etiologies, and clinical presentations vary from an asymptomatic. Rarely it can be fatal also if there's a cardiac tamponade, and usually they present like dyspnea, weakness, chest pain, which is more in the supine position and which usually gets relieved in the sitting position, and rarely they can also lead to hemodynamic compromise if there is a cardiac tamponade. And echo is the imaging modality of choice, definitely, and of course the targeted therapy for the underlying cause. And if need be, if there's a moderate to severe effusions, you have to do what is called as a either needle or a balloon pericardiocentesis. And in chronic conditions like malignancies, sclerosing therapy also may help. With this, I end my talk. If there are any questions from the audience, I am very happy to answer them. I once again thank the IJCP for this opportunity. Thank you.
Thank you so much, sir, for your wonderful presentation. We have some questions from our audience if you'd like to take that up.
Thank you. Yeah, definitely.
Yeah. So, sir, the first question is, what are the current gaps in our understanding of precardial effusion, and where do you see opportunities for the future research?
I think whenever there is a discomfort which is related to the posture, especially the chest pain, and if there's a complaining of a breathlessness, which are related to the posture, which is more in the lying down and gets relieved in the sitting position. One of the differential diagnosis you have to keep is a pericardial effusion, and that has to be investigated in the form of a echo only. X-ray also may not be able to pick up. ECG also sometimes may not be able to pick up except non-specific STT changes. So in that condition, especially if you be able to hear a pericardial rub, or if the chest pain is radiating to the left acromion fossa or left shoulder region, and you have to immediately suspect is there any pericardial effusion, and you have to investigate. Especially the investigation of choice is through echocardiograph only.
Thank
I
you so
think,
much, sir.
yeah. Etiology definitely varies. If it's an acute, I told you it could be just infectious. If it's a chronic, it could be so many other causes: tuberculosis, malignancy, connective tissue disorders. So long standing, you have to investigate. What is the reason? Thank you.
Thank you, sir. The next question from our audience is, are there notable differences in the presentation and management of a pericardial effusion in pediatric patient compared to adults?
I don't think they also manifest in the same way. Now, but usually in the pediatric age, no. Many times you have to record you have to look for the pulses, paradoxes, and also the heart sounds, because they are most often they are thin walled chest, and you have to auscultate. And if there's a hemodynamic instability, many times blood pressure is rarely seen in pediatric age, but you have to look here. And blood pressure is important, the pulse rate is important, the audibility of the heart sounds is important, and is there any rub is important. All these you have to give more importance in children, because sometimes I told you is a negligence. The BP may not be recorded at all. Even the pulse may not be seen at all in children. So that's why you should give more attention there. Is there any paradoxical pulse? Whether the heart sounds are well heard or not? Is there any pericardial rub? Is the JVP is raised? All these things are, and is there any cardiomegaly? All these are very important in children, but the signs do not much vary. Same signs, whatever I have told you, history as well as the science, same thing applies to the pediatric age also.
Thank you, sir. The last question from our audience is, what are the key clinical features that should prompt a physician to suspect pericardial effusion?
I told you typical is a Beck's triad, but it is hardly seen in many patients. It's hardly about 15 to 20, but that means hardly 1/5 may be able to demonstrate that. I told you what is Beck's triad is a hypotension, tachycardia, raised JVP, and muffled heart sounds. That is a triad there in the Beck's triad, but hardly it is seen in most of the patients. And the other I told you, Ewart sign, that is on the back side, on the left infrascapular area, there can be a dullness. There can be sometimes tubular breath sounds and egophony. And sometimes, if the pericardial effusion is large, muffled heart sounds may be there, cardiomegaly can be there, second space can be dull to percuss, especially in lying down position, and sometimes borders can be enlarged in the percussion. These are just signs are very minimal, sometimes asymptomatic also. But you have to, I told you, you should suspect and send, especially when there's a hemodynamic instability. And so paradoxical pulses, paradoxes also can be made out when they take inspiration and expiration. That has to be recorded with the blood pressure, definitely. And many times people may miss it because they don't know how to look for it. So the expiration, the first sound may be loud, and inspiration when they take so you have to gradually decrease the BP just to see whether multiple sounds are heard in inspiration. So that is how we should make out the pulses paradoxes. So that is the clinical signs are very important. Definitely, the diagnostic of choice is again echocardiogram. The moment you suspect, just get an echocardiogram. That is the diagnostic modality. Thank you.
Thank you, sir. Thank you for answering all our questions. Before concluding today's session, sir, any last remark from you?
This is one of the rare cause, but definitely an important cause. One should keep it in mind. Sometimes viral infections can lead to pericarditis effusions, and even traumatic injuries. Following myocardial infarction, we have seen pericardial effusion. Congestive heart failure, we have seen pericardial effusions. Of course, chronic kidney disease, many they have got either a mild or a moderate pericardial effusions. So these are the clinical conditions. You have to keep it in mind and look for it. And I told you, even in rheumatic fever, if you hear a rub, if there's a pericardial effusion, if you see in the echocardiogram, you should suspect that there's a carditis. That's very, very important. That means there's an activity. That activity has to be again treated with the help of a high dose aspirin, or sometimes you may have to give even methylprednisolone, all these things. So, even when doing interventions, if there's a hypotension, you should suspect is there any during coronary angioplasties, balloon mitral valvuloplasties. I told you septal punctures. You must suspect if there's a hypotension, quickly do an echo and find out is there any pericardial effusion, which is traumatic. And definitely, and I told you even in dissection type A, in hypertensive individuals, aortic dissections, if you find an echo, if you find a pericardial effusion, you must suspect that is a type A dissection and send for surgery, all these things. So all these are very, very important. You must keep it in mind. Ultimately, your clinical suspicion is very, very important. Thank you.
Thank you, sir, for joining us today. With your permission, I would like to conclude today's session. Thank you.
Thank you.